Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Associate Professor Mark Lurie. He's an associate professor of epidemiology at Brown University. And we're going to talk about, some about HIV, a bit about coronavirus, various infectious diseases. So, Mark, thanks for coming.
Thanks for having me.
Yeah. Well, tell me, what got you into epidemiology, and how long have you been working in it, first of all?
So I started in epidemiology in the early 90s. It was not a direct path for me. I had no idea really even what epidemiology or public health was. I was raised by, my dad was a doctor, and so I knew what medicine was, and I knew that I certainly wanted to avoid that in my life. But I didn't know public health was an option until I was doing a master's degree in African history. I'm from South Africa, so I've had a lifelong kind of interest in Africa, but in particularly in South Africa and apartheid and its sort of long-term legacy to this day. What I came across as a historian was a fascinating study that looked at the early spread of tuberculosis in Southern Africa. And to cut a long story short, essentially what happened was with the discovery of gold in the late 1800s, you had large numbers of young men congregating around the gold mines. Obviously, the underground conditions were highly conducive to the spread of tuberculosis. You're working in a hot, dusty environment with lots of silica dust, which weakens the lungs and makes you more susceptible to tuberculosis. And above ground, the conditions are perfectly ripe for the spread of TB to other miners because people are living in very close social quarters. That we could have all guessed, but what Randy Packard, the author of this book, White Plague, Black Labor, showed was that as a result of the patterns of migration that have been ingrained in South Africa, the first spread of TB were in these urban hotspots, oftentimes around the mines. And then through a very efficient system of migrant labor that is sending those men back to rural areas at that point, really once a year around Christmas time when they got a break, was a very efficient means of spreading tuberculosis then to rural areas, which had never before seen TB and therefore had devastating impact. I came around in the early 1990s when HIV was already an issue in this country, but not really yet established itself in sub-Saharan Africa. And it was clear to me, having read Packard and understanding the history of tuberculosis, that the very conditions that he described in the early 1900s were very much still in existence today. The long-term impact of a migrant labor system in South Africa meant that most of the people that there's a large amount of migration from rural areas to urban areas, and that much of it is temporary, and much of it is amongst men seeking employment who then return home sort of later in life or multiple times throughout the year. And it was clear to me that HIV was going to follow a very kind of similar spread that Packard had described, because those conditions were so similar, and still you had those hostels that were exacerbating poor living conditions. But in the case of HIV, around those hostels, you saw a development of a kind of industry to service those people, both sexually and with alcohol. And those things kind of fueled the spread of HIV, first on the gold mines in those hotspots, and then once again very efficiently distributed throughout Southern Africa when men migrated back home. So that's how I got into it. And my early work was in the in a province of South Africa called KwaZulu-Natal, which turns out to be literally the epicenter of the HIV epidemic, probably the place where we have measured the highest prevalence and incidence of HIV in the world. Also turned out to be a place with a very high amount of migration to the mines and to other places, and I don't think those two things are coincidental. When I went back to South Africa in the early 1990s, or 1994, it was just after Mandela had been elected, the first democratic opportunity for the majority of South Africans, and a time of great hope, and also a time really at the beginning of the epidemic where some serious mistakes were made that exacerbated the epidemic later on. And indeed, I see some similar kinds of mistakes that we're making today with coronavirus.
Yeah, so, okay, you have very unique insights into what's going on right now. So, yeah, let me know, what are your thoughts? You see it with practiced eyes. So what do you think that nations are doing right and doing wrong in regards to coronavirus? And what do you see as the path ahead?
So thinking of just a little bit more broadly, like the things that intersect, where my work intersects is the first is around the issue of migration and human movement. And if we think of that kind of historically, it's remarkable to think that 3 or 4 generations ago, the vast majority of people never strayed more than 5 or 10 miles from their house that they were born, right? They kept a very, very limited geographical footprint. And over the course of the last couple of generations, that has changed absolutely and completely in human existence. And we're all part of a mobile, interconnected world. And of course, that's how infectious diseases move around. So that's sort of one lesson, is the importance of human movement, of contact between people, because after all, the thing that infectious diseases have in common is they spread between people, and therefore they're going to follow the kind of physical, geographical movement of people. Another thing that I think is really important, and that sort of also is draws some parallels to the HIV epidemic, is that infectious disease epidemics tend to unfold in a very short periods of time, right? Unlike cancers and things which are 10 or 12 or 15-year trajectories, infectious diseases happen in a much more contracted period of time. So think of where we are today with COVID. We've got 8 million infections globally of a disease that 6 months ago nobody had ever heard of and probably never existed. So in a very short period of time, this disease has been able to propagate the globe very, very efficiently. And a corollary to the rapidity with which these things happen is the importance of early intervention. So as you wait and delay to intervene, the kind of accumulation of cases that you miss prior to intervention makes it very difficult to intervene effectively, which is a complicated way of saying you get much more bang for the buck early in the epidemic when you intervene early than when you do later. And if you think about that, in the US now, we've got multiple tens of thousands of ongoing cases. So to trace all of those people and the contacts of all of those people, that's a huge logistical undertaking that's very, very difficult to do. However, if we'd done it effectively at the beginning of the epidemic, where we only had a few hundred or a few thousand cases, we would have stemmed the flow of the epidemic. So the importance of intervening kind of early and effectively. And then, of course, there's a broader kind of global health message, which is about the importance of consistent and accurate health messages from trustworthy people. And that's clearly something that we've lacked in this country in relation to COVID. In South Africa as well, early in the epidemic, we had a president who didn't think that HIV caused AIDS, and a minister of health who thought that antiretrovirals were no good, but people instead should be eating beetroot and garlic. So we've had our fair share of misinformation, and those things I think are highly detrimental to controlling an epidemic, because they lead to conspiracy theories, they lead to ignorance, and they lead to confusion. And those are all of the things that one really wants to avoid when you have a small amount of time to address a really, really major issue.
Well, I've even heard that there was myths going around with HIV that if you sleep with a virgin, it'll cure you, and just all kinds of crazy stuff.
Indeed, I mean that was an early one of many early kind of theories about of sham cures and treatments for HIV that we've been hearing about for a very long time. Another sort of pressing parallel, something to think about is even though we're 35, 40 years into the HIV epidemic, we don't yet have an effective vaccine. We've tried multiple vaccines in human populations, and none of them have been, anything more than remotely encouraging. In the vaccine situation with COVID, we are trying to compress a timeline that usually is, much, much longer into a very short period of time. So HIV, we've never even developed, even over the last 35 years of knowing about the virus vaccine. On average, it takes about 4 years to develop a vaccine, and we're hoping to develop one with coronavirus in something around a year. The president will tell you it's around the corner and it's about to be available, but it's obvious that it's quite a long way away, and even a year is an incredibly optimistic prediction, which is not to say that there isn't an unprecedented effort underway with multiple vaccines being developed, and some of them already in testing, even some factories being built to produce vaccines about whose efficacy we don't even yet know. So they're trying to do things like that to compress the timeline so that if we do find a vaccine that we can rapidly scale up production, because after all, it's something that we're going to want to get to a vast majority of the global population, which is somewhere around 8 billion people at this point.
So with HIV, I mean, how many people a year does it kill nowadays? And it's been around since the 80s. It just seems like everyone's gotten used to it, and it's no big deal, even though it's a huge deal.
No, that's true. And there's no doubt that there have been huge successes in HIV, even though we don't have a vaccine. What we do have is very effective treatment, so that people who get on treatment early and are able to remain on treatment can essentially have about the same life expectancy as people who are uninfected with HIV. So it is remarkable in the sense that we do have effective treatment. The problem is that, as is always the case, the wealthy are more likely to get access to those treatments, and poorer countries, historically have struggled. And there's still, many people in sub-Saharan Africa, which remains the epicenter, who are not yet on treatment. And equally importantly is that every year we're getting, tens of thousands of new infections. So we haven't stemmed the flow of new infections, and we continue to add to that. But again, the kind of biggest weapon that we have in our arsenal is treatment, which is fabulous if you're infected, and it can not only extend your lifespan and allow you to return to very much a kind of normal physical activity, but it also lowers the probability that you will infect other people. So it has a kind of individual and population level benefit. And we've seen that in the countries that are most impacted by HIV over the last decade. Those are the ones that have actually seen the largest reduction in the number of new infections. So they haven't completely eliminated new infections, but they've reduced the amount of new infections significantly. And that's sort of true pretty much across Southern Africa. Most of that, I personally believe, is due to the public health impact of large scale up of antiretroviral therapy. And so that's where we stand with the epidemic today. You are right that it's been a long time since HIV was the kind of flavor of the month that we all talked about and raised money for, and was very much on our radars and front pages. and that is obviously not the case today. But which is not to say that the end of HIV is anywhere near in sight.
So, what about the world's reaction to coronavirus? Do you think it's? I mean, I don't know. Besides, I guess the plagues of old, it doesn't seem like there's been this much of a response. Not even close. What's your thoughts on it?
No, I think that's probably fair to say that this is probably the kind of largest public health intervention that's ever occurred. I can't think of anything short of the rollout of antiretroviral therapy, which has impacted, tens of millions of people across the world. But this is something that impacted certainly a much larger proportion of people. And it's also something that because of lockdowns or stay-at-home orders that were widespread across the globe, that somewhere close to the majority of the global population actually changed their behavior, at least for several months. So in that way, it's unprecedented. And I think it's fair to say, at least from the data that we have from the United States, that the lockdowns or stay-at-home orders, whatever you want to call them, were largely effective. And I think there's some data starting to show that, including some of my own work that we just submitted for peer review and hopefully for publication fairly soon. That's looking at what we call doubling time, which is a kind of measure of how quickly the epidemic is spreading. And we found something quite interesting, which is that across the United States, the doubling time has increased significantly when you compare the pre-lockdown period to the lockdown period. So that's a good thing. It means it's taking us significantly longer. In fact, it's taking us 80% longer for the number of cases to double during the lockdown period as compared to the pre-lockdown period. So things slowed down considerably across the U.S. when we went into lockdown. There were 5 states.
That was the message, though, is flatten the curve. But now what? I mean, it caused untold damage to economies. Other diseases were ignored. Like we talked about offline, cancer screenings weren't done. A lot of regular medical care was labeled as elective, which is, a false label, I believe. And there's just been mass suffering. So wonderful. We've flattened that curve. But what about everything else? And what from here? You're just going to keep locking. I mean, it's not going to go away, it looks like, at all. So what do? You just keep locking down people forever? It's not going to work. What's the path?
No, I think all of those things are true. And I think it is increasingly difficult to keep locking people down. And I think now that we've lightened those restrictions, we've given people the key to open their doors to the lockdown. It's going to be doubly difficult to then ask people to lock down again after that. And that's my major concern. I personally believe that right now we're producing about 20,000 new cases a day in the United States, and that's been the case for quite a long period of time. It's a very, very flat curve. It is not a curve that is noticeably going down, but if anything, it's plateaued and continues to produce roughly 20,000 cases a day. So that 20,000 cases a day is 600,000 cases a month. That is an awful lot of cases, and we get about 1,000 deaths a day, which is 30,000 deaths per month by some current modeling estimates. By the end of the summer, we're going to have another 100,000 deaths. So it's true that we've ignored other things, but the scale and scope of what the coronavirus presents us and what it would have looked like had we not intervened, at least early and relatively effectively, I think is actually mind-boggling. And it's easy to say, look at all the bad side effects and the shutdown of the economy. The truth is, if we hadn't done that, the numbers that we were seeing would be truly catastrophic and unable to be understood or dealt with in any kind of meaningful way. And I don't think that's what anybody wants, right? What we're looking for is the right balance where we can return to a kind of normalcy, but we have to be able to do that safely. I think what we're getting into is a false sense of complacency. And I see that going on for the next couple of months, partly because summertime is here. The virus spreads slightly less efficiently in warm weather. And also people will be outdoors a lot more, and it spreads less efficiently outdoors. So there's going to be, I think, a kind of continuation of the numbers that we've been seeing over the last couple of months without a drastic reduction. And come the fall and the winter, when flu season comes around, when people are forced to be indoors, and when we're no longer going to be wanting to pay serious attention to lockdown orders and other kind of public health initiatives, then I think we are potentially in for something that is even worse than what we've already experienced.
So, even worse, I mean, the mortality rate, again, numbers still bouncing around. I've heard 0.26%. The higher percentages, I don't know if they apply or not. I mean, who knows? But again, why is this happening when all these other diseases, it's totally okay to die from them? Why haven't we locked down because of driving cars or HIV or, cancer or things like that? Like, it just seems like this disease is the only one that matters. And other ones, it's like, yep, people die, no problem. It's fine. And I don't see any calculus on, sure, maybe the lockdowns have helped and to stem the spread of coronavirus, but what have been the externalities? What have been the negative parts? I don't see any calculus of that, and I don't see any attention being paid to it. And I also don't see what's the plan from here. There is no plan, it seems like. There's, at least in the U.S., there's at least 50 different plans, if there are any. And I mean, is anyone even trying to make sense of this? Are they allowed to say anything without being censored? Is there anything in place at all?
I mean, look, I think a couple of issues there. I think you make a valid point that we couldn't simply shut down all healthcare and all of society because there's a virus. It is different than car accidents and other things in that it is spread from humans to humans. So shutting down and limiting human contact is a kind of known effective intervention. That doesn't make any sense to shut down car accidents unless you want to just stop people from driving completely, which actually we've done in a way during this pandemic, and no doubt later we will see the positive impact on that, which is that there'll be fewer traffic deaths. You are right. There are multiple negative impacts that are not being addressed. I wouldn't defend that for 1 second, and I would hope that we could be an advanced enough country that we could do multiple things at once and not have to only address the HIV, the coronavirus epidemic, but also be able to deal with the multiple other health issues that we're facing. I would say it's also worth thinking about some of the flip side of the coin, some of the positive things that have come out of this. And I know that's not easy to do because we're all sick of being locked down and worrying about our relatives and our own health. But we have drastically reduced air pollution. We've drastically reduced fuel consumption. We have allowed, at least temporarily, some animals to kind of regain their habitat. So there are a few positive things that come out of it, and not in any way do they undo the terrible horror that we're seeing as a result of COVID and the many things that we aren't seeing that you have well pointed out are continue to go on in the background because people don't stop dying from other things. They're still dying from malaria and TB and tuberculosis and many other things. So that all remains true. Yeah.
So, I mean, I guess, obviously there's no answer. Me being in the U.S., obviously I'm U.S. centric, but I don't know. Do you think the world is just waiting for the U.S. to do something and everyone follows? Or, I mean, do you see the dynamic of what's going on with coronavirus in various countries in the world? Or is that, I don't hear anything. I mean, when there was hotspots, sure, but otherwise I hear nothing. Is anyone even looking or listening? And what are other countries doing?
Yeah, I mean, I think let's put it this way. The countries that are succeeding are not waiting around for the United States lead. If anything, we're leading them to the bottom. And the few places that are seeing the greatest surges right now, which I would point out, Brazil and Russia are both places that in a way have followed the US's lead with disinformation, with denial, with the disorganized response. And that's precisely why they're competing with us for the very bottom, which is to say for the greatest number of cases. A lot of countries, there've been, almost as many variations of an effort to stem COVID as there are countries. As you probably know, some Scandinavian countries took a very different approach. Sweden, in particular, made a decision that, based on the understanding that older people are much more vulnerable to COVID, that their lockdown would mostly involve older people and would allow younger people to continue to move around. And even, many places didn't cancel school. That's one kind of extreme example of a different way of addressing COVID. Other more authoritarian places like China, obviously, had a major lockdown where they really shut everything down in a way that I think, makes what we did in the U.S., look kind of sad. Sure, we had a major shutdown, but I think nothing in relation to the way that China and a few other places were able to shut down. A few places are blessed by geography. If you're a small island like New Zealand, then it's easier to keep the virus out and to control it when it comes in. I think the one thing that many countries that are succeeding have in common is that they're doing lots and lots of testing. And that's one of the things that truly scares me in the United States, is that we're not testing anywhere near the amount of people per day that we should.
If you test, what good is that? So you test people, that's a snapshot that day, either have it or they don't have it. Then what?
Oh no, but that's critical. That the testing is critical, not only because it identifies people, but because it allows you to isolate those people to make sure that they don't infect anyone else, and to find their contacts to make sure that their contacts don't either are themselves not infected or don't infect other people. So testing in isolation, gives you a snapshot, but it's part of a broader strategy to isolate and to find contacts of those people so that you can stop the new spread of infection.
But you can't stop it forever. People have to live, so they're going to come out sometime, and then at some point they're going to get infected. You can't stop the virus is unstoppable. So a certain percentage will have to get it at some point.
The hope is, honestly, the strategy is that we try to minimize what proportion of people get it for now until we have a vaccine. You're right about that the virus right now is unstoppable, and without a vaccine, unless it burns itself out, it's likely to infect a very large proportion of us.
So what if they did that with AIDS? The whole world would be locked down for 20 years until they found, or no one's allowed to have sex, for 20, 30 years until they found antivirals. It doesn't, if a vaccine's going to take years, who knows if it's even possible? It makes no sense.
I'll tell you one thing you won't be able to control is other people's sex lives. I think I've learned that more than anything. You can tell people not to have sex, but that's a sure way to fail. But the broader point that, how I think is, how do we balance the immediate large crisis that is undeniable with the kind of background other things that are going on? And I certainly don't have the answer to that. I think if we had erred in the other direction, which is to say we had less lockdown and less restriction, I think we would be in terrible shape. I personally think that 1,000 deaths a day in the United States is a crime. It doesn't have to happen, and it shouldn't happen. and we have, the wealthiest country in the world. We should be able to avoid this. So, I think, it raises and points to all kinds of problems that we have in our health system and, throughout our society. And these things are going to take a long time to heal. But to look away and pretend that COVID is not there, or to try to kind of simultaneously deal with it, I think is very, very difficult. This is a highly infectious disease, and having people in close contact with one another is the precise conditions that the virus spreads. So the only prevention method that we have in our tool bag right now, because we don't have a vaccine, is to simply keep people apart and make sure that they have fewer contacts with one another.
Why only a vaccine? Why not antivirals? Why does it have to be a vaccine? Why can't there be treatment for it so it's not so bad? And the death rate goes from, let's say 1% to 1/10 of 1%.
Sure.
We're happy with that with flu. No one cares that the flu rate could be 1/10 of 1%, but we're totally cool with that. We don't do anything. And in the U.S. alone, CDC says 30 to 70,000 people die each year. That's no problem. Everyone's cool with that. That's fine.
I wouldn't say. No, I think that's an exaggeration. I wouldn't say everyone's cool with that. I think that that is something that occurs in this country. That there are multiple public health and medical officials who are trying to reduce that number in a whole variety of ways every year. I don't think we just accept that sort of happens as background noise. I think there's a real effort to try to eliminate that. So it's not that we turn a blind eye to that. But 70,000 deaths over 1 year for flu is significant. In the course of 6 months, we've seen 1.5 times that number already for COVID. So,
Right.
By that calculation, we should be turning huge amount of attention to COVID.
No, I agree we should give it attention, but I just don't see anyone saying, I think we're going to have to get to the point where we're going to say, look, there has to be this balance. There's going to be a certain amount of death. No one wants that. Maybe they need to set parameters on, okay, well, maybe that's what they're doing. Number of deaths, as soon as it gets to this level, then you have to implement some level of restriction. And then when it eases off, you open up again. And then you go down and up and down and up. I don't know. Maybe that's where it's headed.
That's essentially the kinds of guidelines that the White House put out for reopening. The problem is that nobody's following those at all. Everybody has their own kind of formula. And even their own formulas, they're not really following. But I want to get back to an interesting point that you raised about why only a vaccine, why not treatment? And you're right that treatment could have a major impact. There's no doubt about that. It's more likely to have an individual level impact than a population level impact, which is to say that unless you're able to get people on treatment very, very early, the treatment itself is not likely to slow the spread of new infections. And that, and so even if treatment just...
What is the goal? Is the goal for people not to die? Or is the goal for people not to get infected?
There are multiple goals, and a treatment.
What's wrong with being infected? I mean, people get sick of all kinds of things. So it doesn't make sense. Again, it's not going away. Stopping someone from being infected, I don't think that's really, that's just part of life. Everyone gets sickness, It's like saying, I don't want someone to die or to grow old. People are going to get infected by all kinds of things, but if you could stop them from dying, well, that's like a huge win.
No, so but by that calculation, you'd say, why prevent anything? Everybody's going to die, so why bother preventing anything? And why not have, unprotected sex with as many people as you want and come in close contact with people who have Ebola? That doesn't make any sense. I'm just
pointing out the two extremes.
To that.
Well, I'm not saying go to that extreme, but I think people are going to the other extreme. We can't let people get infected. Well, why not? What's wrong with that? If there is an antiviral, if most people are going to be okay with it, maybe that's the best you can do.
So that may be the next step, the next best step that we have. That we find some treatment. And in fact, just a few days ago, there's some news that one, maybe even two treatments amongst people who are very ill with COVID, right? This is not the average COVID infection, but amongst the sickest people who end up in hospital, it looks like some new drugs can cut the death rate by about a third. So that's very significant. But it's not significant if you're one of the other 2/3 where it doesn't cut the death rate.
Right.
So, I think a kind of cavalier attitude about, we're all going to get infected, so let's just do that and move on. Well, that's means that you're willing to accept, about somewhere between 0.5% and 1% of the entire U.S. population dying. And I don't think we should be willing to accept that. I think that's an avoidable, possibility that with, decent public health and proper messaging and proper investment, we should be able to avoid that. There's no reason why that should.
What does avoid it mean, though? 0 deaths from COVID, or 0.5%'s okay versus 1%? What does avoid it? I mean, that's the problem. I'm not asking you to answer it, but
no, of course. So nobody's going to quantify. Nobody's going to quantify and say, okay, 0.5% of deaths is okay, but 0.75% is not okay. I mean, to me, any avoidable death is not okay. So we should be doing, whatever we can to avoid any death whatsoever. If we
but that's not being done with
half, then that's a huge advantage that we currently have.
Right.
For me, as a public health person, what I'm most interested in is, of course, I'm worried about people dying and the terrible outcomes that occur from COVID, but I'm equally worried, if not more so, about the spread from one person to another. And interestingly, so going back to HIV, we know that with antiretrovirals, getting people on antiretrovirals, as I was saying before, not only has this positive individual impact, but what it also does is lowers the amount of virus in that person's body, and therefore it lowers the probability that they can transmit to other people. So it's at both individual level and a population level impact. Now, if we had a treatment of the kind that you're describing, that would not only impact people who are the sickest people from COVID, but could potentially change the course of COVID for everybody who was infected. And we were able to effectively identify enough people early on in the disease, then you could see how a treatment like that, which is going to render people less infectious and therefore less likely to infect other people, could have a kind of population level impact. And that's what I would be looking for. Sure, I want to reduce the proportion of people who die, but I also want to reduce the number of new infections. And for a treatment to be effective there, you would have to identify people very, very early on in the course of the disease. We know that a certain amount of transmission happens even before people have symptoms. So to be effective, then you have to identify people who are infected prior to them actually having symptoms. And that brings us full circle back to the importance of testing, because unless you're testing people frequently and a large proportion of the population, you're never going to be able to identify enough people who are current spreaders before they develop symptoms of the disease, and therefore before they spread the disease to other people.
Yeah, I'm just glad that all diseases aren't treated like this, because no one would be able to do anything. So,
and I share your frustration. We've all been locked up, and I think some of the ill effects of that have started to leak out in the last couple of weeks in terms of the kind of pent up frustration and understandable anger that many people in this country are feeling. So yeah, I hate to be a doomsdayer, but there are many things about the current handling of the COVID epidemic in this country that really leave a lot to be desired and are leaving us with many more infections in this country than we need to have.
Yeah. Well, very good. Mark, what's the best way for people to find out more about you?
I would say have a look at the website of the International Health Institute at Brown University, where I am employed and a faculty member.
Okay. Any particular publications that you've come out with or about to come out with that you want to draw people's attention to?
Sure. So the things that I talked about early on about migration and HIV. Some of that early work was published in the early 2000s in the journal AIDS and Sexually Transmitted Diseases. And I'm hoping that a paper I had just submitted to the Journal of Infectious Diseases, or about doubling time of COVID in the United States, will successfully pass through peer review and be published at some time in the not too distant future.
Okay, well, very good. Well, Mark Lurie, thanks for coming on the podcast. I really appreciate it.
Thanks for having me.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.